the problem, our patients just get so sick and they third space a lot of fluid, and it can be really challenging at the bedside to decide, like, is this patient dry or not? They're fluid overloaded, but where is the fluid? And I
Yeah.
think that's where the big challenge comes in. And that's where using things like the passive leg raise test with stroke volume devices, or even like giving the patient, measuring stroke volume and giving a fluid bolus in a very short period of time, like over a minute to 3 minutes, to see what their stroke volume does. Are they going to be fluid or preload responsive? And if not, then you use a pressor. I feel like from a hemodynamic standpoint, that's a whole other podcast episode. But from a hemodynamic standpoint, we have got to start paying attention to this, because fluid overload is not benign and it causes a lot of issues down the road. But to that point, you also can't use a pressor if you don't have enough volume.
Hello, everyone. Welcome back to another episode of the CRNA's Prep Academy podcast. I'm Jenny Finnell, your host, and today we have a very special guest. She's back to the show, Nicole Kupchik. Welcome, Nicole.
Hey, everyone.
Yeah, so today, you guys, I'm so excited. For those of you who are not aware, Nicole just launched her book called Critical Care Survival Guide, if you can see it here if you're watching YouTube. And this thing is amazing. It is chock full of very organized tabs, such as hemodynamics, cardiac medications, different cardiac parameters, respiratory, neuro, renal, endocrine, GI, blood products, IV fluids, and everything else that you can possibly imagine. And today we're actually going to hit 5 cardiac medications that I feel like you guys can never get enough of. And I know it's a very heavy topic for anesthesia school and CRNA interviews. And so I brought Nicole on the show today to go over these medications and share some of this wonderful insight that is in this amazing guide that I highly recommend that you pick up. It will be in the show notes linked below or in the YouTube comments. So make sure you drop down and check that out. Welcome, Nicole, and thank you for joining us.
Oh, thanks for having me again, Jenny.
Yeah, it's always a pleasure and honor to have you. And yeah, this is exciting because I love getting nerdy like this and talking about, pharmacology, pathophysiology. And I know our audience could use a lot of refreshing and just deep dive more than just the surface level, I think is what's really key, which is what I love about your book, because it's definitely more than just the surface level. You add a lot of value in here. So one of the first drugs we're going to talk about today is norepi. So let's go ahead and get into that.
Yeah, it was interesting. So when I wrote the book, I really tried to write it just with the idea of, like, there are so many new people in healthcare. And one of the things to kind of note is I didn't call it the Critical Care Nursing Survival Guide. I really wrote it so that it could be used by providers, nurses, who's ever at the bedside. In my 30th year as a nurse, and a lot of these drugs are just second nature to me. But then I kind of like took a step back and thought, okay, like, if I knew nothing about this drug and it's 2 a.m, like, what would I need to know?
Exactly.
And that's the way I tried to write the entire book. It's 2 a.m. I don't have a lot of resources. Maybe I can trust this woman who wrote this book, like, what do I need to know? And so, yeah, so norepinephrine, first drug right off the bat, when I became a nurse, like, yeah, I'm dating myself. It was called leave a fed, leave them dead, right? Because we used it as like a last ditch effort drug.
That. That's funny.
You never heard that?
No, I have not.
Oh my God.
Leave them
Yeah,
dead.
it was such a 1990s thing, right? But it was one of those drugs, like, it would be like the Hail Mary in somebody who was crashing, and we would use dopamine as a first line drug and blah blah blah. Well, then come to find out, like, when they studied it head to head against dopamine, it came out the winner because it's got like a little bit of beta 1 but more alpha, and so you're not going to get the tachycardias like you do with dopamine, because dopamine's just got so much beta 1 activation, and lots of tachycardias and dysrhythmias and things like that. So I also tried to give, like, in the book, I tried to give a general approach to vasopressors. And one of the things I say with vasopressors is, when you got somebody who's hypotensive, you don't take your time, you crank it and then you dial it back. You need to get their pressure, and ideally, hopefully then secondary, their perfusion to a point where their kidneys aren't going into failure and they're not having other organ damage and ischemia. And so, you've vasopressors, I kind of divided them into catecholamine based and then non-catecholamines. And all your catecholamines are quick on, quick off. So it's 1 to 2 minute onset, like about a 2-minute half-life for all of them. So you titrate quick with those. And so I try to give just like some general guidelines around like how do you use these drugs. And another thing to remember is with a lot of your vasopressors, especially norepinephrine and possibly vasopressin, you're probably going to start seeing more peripheral use of them, because in sepsis, what we're finding out is like, we've probably way overdone it with fluid, and now we need to dial it back. You got a vasodilatory type shock state that it only makes sense start the vasopressors early. And so I put some guidance from the Society of Critical Care Medicine around peripheral use of vasopressors as well. And I try to give just some kind of general guidelines, but just remember, titrate quick with your vasopressors. And always remember as well, what goes up must come down. So, I think we're really good at like getting vasopressor doses up, but you got to remember these things vasoconstrict. And one of the things that the two organs that vasoconstricts quite heavily is the skin and the GI tract. And we don't have a good way of measuring like how those organs are doing. Skin, we can at least see. The GI tract, we cannot. And, just always thinking like when you get to certain doses, especially like norepinephrine, let's say use mics per minute. If you're like at 15 to 20 mics per minute, you need to really be thinking about second line vasopressor, like either vasopressin or low dose epinephrine. So I really try to give guidance around, how you use these drugs without being too verbose.
Yeah, I love that. Is a very high dose epi. Yeah. And I love the fact that you said you can always, you want to make sure you're stabilizing the map and getting the map up versus taking 1 to 2 minutes to keep titrating very, very slowly, because, time is precious. And, the skin aspect of vasopressors, I've seen patients turn gray in my ICU years. They get like a mottled gray look to them, and that's never good. And it's usually for someone who's on multiple pressors. And, but the GI tract, good point, that toxic megacolon, dead gut. I mean, when that type of situation arises, there's usually no coming back from that. Yeah.
No, game's over. Yeah.
Right. So thank you.
And we don't have a great way to measure that. Years ago, and actually in the late 90s, that we were using sublingual circulation parameters. And unfortunately, that device got pulled off the market. There were some issues with development of it, or not development, manufacturing of it. And unfortunately, the device got pulled off the market. So we really have no way of looking at gut circulation. And are we shunting too much blood away from the gut? So just always remember in your head, what goes up must come down, and just do not be shy about backing off the vasopressors as well.
Yeah, 100%. So let's get into what you said. It does beta and alpha. So what's the ratio between like beta and alpha? Is it more alpha, more beta?
So norepinephrine specifically. So what I did was I put like a little chart in the book where I just talk about alpha and beta receptors. So alpha receptors are located in the periphery. Beta 1 are located on the heart. And I always do this little rhyme. It's like beta 1, you've got 1 heart. Beta 2, you've got 2 lungs. And this little rhyme I always use to remember like where your receptors are located. Norepinephrine, it has a lot of alpha. So I gave it, I think, 4 pluses on alpha. And then I gave it a 1 to 2 plus on beta 1. So you're going to mostly get peripheral vasoconstriction with a little bit of inotropy, meaning you'll get a little bit of contractility assistance, but not so much that the patient gets tachycardic from it. So, and of course, a lot of it's dose dependent. You always want to try to keep these drugs, like I said, initially you crank it and then you back off, but you want to keep these drugs at lowest doses as possible because of all the vasoconstriction that they cause. I mean, we've seen patients lose, I always say, ears and nose, fingers and toes, from these drugs because they cause so much vasoconstriction.
No, I love that. And I love how you mentioned the heart rate. One thing that's really, really vital, I know we think about a lot in anesthesia, you guys, is the heart rate. It puts a lot of oxygen demand. So the tachycardia essentially can actually cause more ischemia because your demand is higher for oxygen and you're utilizing it much more quickly with tachycardia. So drugs that cause tachycardia can actually worsen cardiac ischemia. So that's something to keep in mind too. And that's very important as you're titrating vasopressors that have those effects.
Yeah, I totally agree. Yeah, the tachycardia. And you remember, especially if you got a cardiac patient, like what happens during diastole, your coronaries are perfused. And, if you've got a tachycardic patient, that coronary perfusion time is really, really, really diminished. So totally a great point, Jenny. Yeah.
Yeah. Thank you. Yeah, that is great. What would you say you would start someone off on with levo? And how would you, since you mentioned you want to titrate it quickly to get the blood pressure up, how would you titrate it? I know based on like standard protocol, isn't it like usually 0.02 to 0.05, right?
Yeah, there's no protocol per se, like, because nurses always ask me, like,
yeah, exactly.
hospitals might have a protocol.
Yes, exactly.
But yeah, and this is where the Joint Commission, that's a whole nother topic too, where the Joint Commission has come in and they've really tried to regiment, and kind of make us like protocolize how we titrate vasopressors. I'm sorry, when you got somebody who's hypotensive, you cannot protocolize that.
Yes.
You have to titrate to effect.
Okay. Interesting. So
yeah,
you wouldn't be afraid to jump all the way. I mean, you would just go to what you think is necessary, or how would you judge where to go?
Yeah, I mean, it depends if you're using mics per minute or mics per kilo per minute. But like, so for example, like mics per minute, I might start at like 5 mics per minute and then go up to 10 and then, maybe up to 20. But then you can crank it back down because every minute that your patient is hypotensive or hypoperfused, you are risking organ damage. It's, specifically kidneys are a big one. I worry about the GI tract. We worry about,
brain.
neuroperfusion, cerebral perfusion. So, this is the art of being at the bedside, right? This is the art. And then the science tells us back off as quickly as you can, right? Where you want to use the lowest dose needed. I know people always say to me, like, what's the best dose? It's like the one that makes them pee, right? If you've got somebody who's chronically hypertensive, a MAP of 65 probably won't do it,
Right. I love that point.
You've just got to look at your patient and see what they need.
Yeah, I love that you said, you got to see what their baseline is, because someone who's always living with a MAP in the 70s, that's probably what their body's used to, and they need that to perfuse. So a MAP of 55 is not going to cut it if they're living at a MAP of 75 most of the time. And also the renal, the urine output, what is the urine output? And I've always heard that's kind of a later sign. I mean, yes, it's a sign, but it's kind of once you see the urine output start to dip, it's like, okay, you're already kind of behind the 8 ball a little bit.
I'm sure.
Yeah. But it is.
I'm sure. And then, since we're talking about urine, I'm just going to mention this. Like, there is like, I think at the bedside, we always shoot for urine output of 30 mils per hour. Like where did that come from? I have no clue. There's no science to support 30 mils per hour. I'm 5'2". And what I always do when I'm live in classes is I have the tallest person in the room come stand next to me. And I always say, who is 30 mils an hour an appropriate urine output for, me or this person who's 6'2"? And the answer is it's appropriate for me, probably not the 6'2" person. And if you look at any renal guideline, they're always going to recommend a 0.5 ml per kilo per hour.
Right.
So, just really, you have to rethink even like your urine output goals as well.
Yeah, I love that you mentioned 0.5 ml per kilo per hour. You guys should remember that. That is the same formula that we go by in the operating room, especially if you're doing cases like open hearts. So, the 30 mLs per hour, if you take like the standard 70 kilo patient, then, it works out. But again, you have to, they're 35 mLs per hour, whatever it ends up being. But that's where that 30 ml came by, was the set average weight of 70 kilos, so knowing that that's not always the average weight per kilo, go by the 0.5 ml per kilo per hour as what you're aiming for your urine output. And obviously when you're working with peds, that matters too, because peds are various sizes. So you have to take that into consideration. And also depending on the patient's age too, your body water is different too. So keep that in mind as well. The older you get, you tend to have less body water, and the younger you are, like a little tiny fluffy little baby has a lot more body water. So understanding that dynamic as well. All right, well, that's great. So I'm trying to think, is there anything else about norepi? Let's talk about like the half-life and maybe like the mechanism of action. I know we talked about like the alpha and beta. Other than causing vasoconstriction and a positive inotropic effect, is there anything else that we should potentially know about the mechanism of action, or maybe what would be the best line of treatment for certain disease processes like sepsis and things of that nature?
Those are the two main ways that it acts. So, It's catecholamine. Like I was saying, all your catecholamines are quick on, quick off. So it's about a 1 to 2 minute onset with about a 2 minute half-life. So it is the first line vasopressor in most guidelines right now, specifically for sepsis as well. And one of the ideas is that, you want to think about a second line vasopressor early, especially in the setting of sepsis. And our guide was always like, when you get to like about 15 to 20 mics per minute, and then, just move the decimal point 2 spots if you're doing mics per kilo per minute, think about adding that second line vasopressor. And vasopressin, it's antidiuretic hormone. So it's going to act through your vasopressin 1 and vasopressin 2 receptors. So it's going to cause vasoconstriction, but it'll also cause the body to hold on to sodium and water. And the half-life of vasopressin is about 10 to 20 minutes. So it's not one of those drugs that you actively titrate. You just kind of put it on. And especially in sepsis, there's some thought that people are ADH deplete.
Mm-hmm.
And so that there's some benefit there. There's some thought that there's synergy between norepinephrine and vasopressin. So it works in a really, really, really different mechanism. The sepsis guidelines with the update in 2021 recommended to start at 0.03 units per minute versus 0.04. And the reason was that there were concerns with gut ischemia. So, any vasopressor, you've got to worry about gut ischemia, again, which is really difficult to identify and measure in patients. So norepinephrine, I would say in most guidelines are going to be your first line vasopressor, but just remember, it is a potent drug. And then, in sepsis, another drug, which unfortunately, I think just because of the pandemic and the cost and timing and everything else, another great drug is angiotensin 2. So Giapreza is the other name for that, or angiotensin 2. And, like some facilities use it as kind of a last ditch effort. Well, here's what I'm going to say about that is any drug used as a last ditch effort is not going to work. It becomes the self-fulfilling prophecy. You've got somebody who's just about dead and you're like, oh, let's start this drug. Oh, that drug doesn't work. Yeah, because they were about dead when you started it, right? So it's not going to work in that situation. So my experience with angiotensin 2 is start it early. It actually got FDA approval as a first line vasopressor, but a lot of people use it as second line, cost being a concern, but it's a great drug. It's angiotensin 2 is a very potent vasoconstrictor. It's something that naturally occurs in our body. And in fact, in heart failure, we block angiotensin 2 because it's such a potent vasoconstrictor. And so that's another drug I would say, if, in sepsis, which is, as a CRNA, you're probably not dealing directly with sepsis, but you have septic patients in the OR.
Mm-hmm.
And so that's another drug that's great to use as well. And it's dosed in nanograms, which is a different way of dosing than what we're used to. So
nanograms. Very cool. Awesome. Well, thank you for sharing all that. Awesome. Well, let's get into epinephrine. That's kind of a big gun, I think, as well, but something that I think is really critical to understand. Let's talk about the mechanism of action and different receptor sites of epi, and maybe even like how it's dose dependent.
Yeah, so epinephrine, like the way it works, all depends on what dose it's at. So when you've got lower doses, it's mostly going to act as a positive inotrope. And that's why we always say, low dose epi. The nice thing, especially in sepsis, there's a lot of cardiac dysfunction in sepsis. And low dose epinephrine is going to give you more positive inotropy, so more of that beta 1 effect. So you're going to get increased strength of contractility. But as you get on higher doses, it's going to vasoconstrict the periphery. And another like wild thing I've seen with epinephrine, and then I saw this a few years back and I started looking in the literature and, oh, this is a thing, is sometimes with epinephrine, what you might see, especially in a septic patient, is you might see this massive increase in lactate. And so one of the thoughts is that it causes a type B lactic acidosis, and that it frees up lactic acid. And, I've heard some providers say, the whole idea is that the body may use it as metabolic fuel. How well supported that is in literature, I'm not totally sure. But you might see this big upswing in lactate levels because it causes a type B lactic acidosis, not type A. The type A lactic acidosis, we see high lactates because of hypotension or hypoperfusion.
Mm-hmm.
Whereas type B lactic acidosis is not life-threatening. You get just an elevation in lactic acid. So we see it with albuterol. We see it with epinephrine, thiamine deficiencies, metformin. different drugs like that. So, just be aware if you're using epinephrine, you might see this kind of escalation of lactate levels.
Interesting. I wonder
So,
how they, oh, sorry, go ahead.
oh no, well, I was going to say the other thing to really watch out for is watch for hyperglycemia. So with epinephrine, you see some insulin resistance and you may see hyperglycemia. So even in non-diabetic patients, they may need some insulin when you're using epinephrine infusions.
A daily dose of inspiration from a CRNA School Prep Academy student. I have been waiting to write this post for a few years now, 3 to be exact. I finally got accepted to CRNA school. Thank you so much to CSBA for everything. I have been a member for 3 years and went to 2 conferences, which was super helpful. I also did 2 mock interviews. I then did the 5-day interview boot camp 3 separate times as well. Here's my story. This has been a lifelong dream of mine since I was 13 years old. My GPA was a 3.2, so not the best, and I refused to take the GRE because I don't feel standardized tests should be used to determine the quality level of a student. I worked at a busy level 1 trauma center for 6 years and was a part of every committee possible. I also had my CCRN, my TNCC. I was charge nurse and a preceptor. I took grad level biochemistry course from Oregon State as well. I applied to over 7 different schools and only got 2 interviews. Rejection was not fun over and over again, and after a failed interview in January, I almost gave up. CSBA helped me so much and gave me the motivation to keep pursuing my dreams. Moral of the story, do not give up. I just love this story so very much. So dear future CRNA, you know who you are. Congratulations. I'm so incredibly proud of you. If you're not already subscribed to our free Future CRNA newsletter, be sure to do so now. Pause this episode and click the link in the show notes or comments below. Cheers to your future. Now back to the show. Interesting. Okay. Well, I think that's a good point to point out about the insulin and hyperglycemia. I'm curious for the lactate, and you say that the levels elevate, are they differentiating between A and B in the test? Because I don't remember them ever doing that. And so I wonder if they would see that as alarming when you said it's really not, that lactate B is not, or type B is not alarming, but how would you know whether the patient's, like, how could you differentiate between just because they went on a drug and now it's increased, or?
Yeah, well, so for example, okay, so I'll just give you an example of a patient who I took care of not too long ago. So it was a patient who was septic, and they were on norepinephrine and vasopressin, and then we added epinephrine, and when we added the epinephrine, so before we added the epinephrine, the last lactate level was, I want to say it was like 3-ish. It was like right around 3. So it was still elevated. And this is a patient who was in shock. They were in septic shock. And when we added the epinephrine, the lactate levels went up to 9 and peaked at 12.
Wow.
But the patient looked better. They were peeing. They were less mottled. They overall looked better, and their SVO2 was better. So we did a spot check. The patient had a triple lumen catheter. And so what we did was we did a spot check. And before we started the epinephrine, I want to say the SVO2 was like 45-ish%, somewhere around there. And then once we added the epinephrine, the SVO2 went up to almost 60%. So the patient physiologically looked better, but they had these crazy, crazy high lactate levels. They were peeing. They were just doing much, much better. Cardiac output was up. Stroke volume was up. SVO2 was better. And we're looking at these like, okay, this patient does not look like a lactate of 12. And then, then we're like, oh, this is actually type B lactic acidosis that's caused from just the body freeing up this this lactate. And so anyway, so we just kind of just let it be. And then the provider wasn't comfortable with it, so we turned off the epinephrine and used dobutamine instead, and the patient's lactate levels cleared.
Okay. Yeah. Well, thank you. That's a great explanation and kind of a scenario that I think you guys should really listen to on repeat, because I think especially, if all you went by was that lab value, you would think that he was doing way worse. But clearly you shared that they painted the picture, but kind of making note of where they start is really key before you start that new drugs, kind of knowing where the lab values, what the last ABG looked like, what the SVO2 was before you start a new drug is really key to being able to say, well, what's the cause and effect relationship? And I think that's a really great point to make. So thank you for saying that. All right. So epi, I know you mentioned the different dosing, cardiac dose, 0.01 to 0.02. We usually did 0.03. But obviously the more you titrate up, the more you're going to get the squeeze. with the alpha
Yeah, more alpha.
receptors.
Yeah.
Mhm.
Yeah, more alpha.
Let's see what else we have on here. Yeah, increased lactate levels, pulmonary edema. What is that caused just from the increased vasoconstriction and kind of the cardiac or like the pulmonary system kind of being
Yeah,
affected?
I think a lot of it depends on what's happening with the patient, but it could be a lot of more demand is higher.
Mm.
There's more resistance toward the lungs, so PVRs go up with this drug depending on the dose. So it depends. I think a lot of it depends on the patient's scenario and what dose you're at. But just like one of those things to kind of like watch out for. So at low dose, I'm not as worried about it. It's more higher doses.
Okay. All right. Awesome. And then you mentioned
Yeah.
myocardial ischemia, which I think we kind of already
Yeah.
briefly covered with the tachycardia kind of being.
It's all demand. Yeah.
Yes. Awesome. All right. So let's move on to Neo, anesthesia's favorite drug, phenylephrine.
I was telling Jenny, I was joking around with Jenny, and I told her when I teach, I always try to like be funny and just be kind of like silly when I teach sometimes. But I always say, who loves neosynephrine, phenylephrine, anesthesia? In fact, they carry mystery unlabeled syringes of it in their pocket. They come in your post-op patient's room, pow pow, leave, and you're like, why is the pressure 220 over 120?
Or this is bad too. I think I was talking to a PACU nurse on a podcast episode. And I mentioned how, and I've never done this, but when I was in clinical training, I saw CRNAs do this, and I'm like, what? They would, and this is not right. So you guys don't do this, but they would go to the PACU and they would put like, I don't know, 500 mics of Neo in whatever's left in their saline bag. So like if their bag had 500 mLs left, they'd squirt the Neo into like, yeah. So then they would obviously give a report to the PACU nurse, and they would just have a little tiny mini infusion of Neo going, and again, not okay. You'll see a lot of things in practice, you guys, that if the light bulb goes off, you have to know that that's not ideal, not a good practice. But PACU nurses are very well aware that sometimes anesthesia does stuff like that. So yeah, Levo, it's a great drug.
That's interesting.
Yeah, I know, right? I know. I feel weird even saying that. I'm like, oh, this is so not okay, but I just know it's done. Let's talk about, the mechanism of action and kind of the effects on different receptor sites and things, and what makes it different from, say, something like Levo or Epi.
Yeah, so phenylephrine is pure alpha, and it's just going to give you peripheral vasoconstriction. It's not going to give you positive inotropy, so you're not going to get extra squeeze. It's going to increase the workload of the heart because it's increasing afterload in the SVR. But like in a lot of patients, that's okay because they're vasodilated, and that's why you're giving it, especially post anesthesia. So so it's gonna work a lot differently now. In some patients, you might actually see reflexive bradycardia from phenylephrine because there's so much peripheral vasoconstriction that they have basically a parasympathetic response to it. And so I would say now one of the things I'm going to say though is that it's actually not recommended in septic patients. There's some data that perhaps it's unsafe in septic patients. It would be interesting to really dig into the whys. I honestly have never dug that deep to figure out why in sepsis. In sepsis, we're always norepinephrine, vasopressin, low dose epi, dobutamine. So, but it's just, remember, it's a pure alpha, so it's just going to tighten up the periphery.
Yeah, my understanding, we didn't ever use it in the NICU. We were always using Levo. But like my girlfriend who worked in the surgical ICU was using Neo drips all the time, and I'm like, well, that's weird. So I remember the thinking it's because like in sepsis and a lot of those types of patients, you have so much cardiac dysfunction that when you're just squeezing the pipe, they can't, the failing pump can't overcome the afterload and increase SVR. So you can actually worsen the heart failure and cause right side of heart failure and backing up the blood. So you needed that positive inotrope with the Levo to kind of overcome the increased SVR. So that's why Levo was always a better choice in sepsis versus someone who, like you said, is more just dealing with a vasoplegic injury and their pump's okay. But I think it's one of those drugs that's so important that you have to have volume. And I stress this all the time in when I train and I precept, because I see that so quickly they go for that without assessing first, is it because they're losing blood or volume or insensible loss, which in a big GI case, you lose a lot, every
third
hour.
Space so much.
Yeah, you third space that too. So there's a lot of things going on. So you cannot give a drug like Neo without adequately replacing the volume that the patient has lost or is losing or needs. So, because I think about it like it's like a closed pipe, it's collapsed. So you're trying to squeeze it more and there's nothing inside the pipe to squeeze.
I think that's a really good point, Jenny. And that would be, I think, super true for any of the vasopressors, right? It's just like you can't use this in a patient who's got a volume issue. You've got to replace the volume. Yeah, the problem, our patients just get so sick and they third space a lot of fluid. And it can be really challenging at the bedside to decide, like, is this patient dry or not? They're fluid overloaded, but where is the fluid? And I think that's where the big challenge comes in. And that's where using things like the passive leg raise test with stroke volume devices, or even like giving the patient, measuring stroke volume and giving a fluid bolus in a very short period of time, like over a minute to 3 minutes, to see what their stroke volume does. Are they going to be fluid or preload responsive? And if not, then you use a pressor. I feel like from a hemodynamic standpoint, that's a whole other podcast episode. But from a hemodynamic standpoint, we have got to start paying attention to this, because fluid overload is not benign and it causes a lot of issues down the road. But to that point, you also can't use a pressor if you don't have enough volume.
Yes, you're right. You have to figure out what it is that they need and then go from there. You don't always have invasive lines to do these things. But like, for example, in anesthesia, like if you don't have any kind of way to measure what their stroke volume is, and if it's not in the ICU with all these really fancy, pretty things, you give a little fluid bolus, see if they're responsive. And then if they are, well, then that's what they needed. If they're not, then they're vasoplegic. So it's really just about kind of figuring out what they need, but being careful that you're not just walking in with a liter. And I'm saying you test them with a 250 bolus or maybe 500 tops, but even 250, you can tell if you give someone 250 if they're going to be fluid responsive. And also understanding like the pathophysiology process. What are their comorbidities? Also, what's the process that's going on? What's the disease process? Or in surgery, what's the surgery? What are their losses? So taking all of that into account before you just assume that they need one thing and trying to kind of be like the scientist and figure it out.
I have to, the one thing I'll just pipe in and say is, heart rate, blood pressure, central venous pressure do not tell you if your patient's going to be fluid responsive. They just don't. And the science is super clear on that. But, if you're using end-tidal CO2, if you're using, if your patient has an art line, you can look at pulse pressure differences. So I would say to all of the CRNAs or future CRNAs listening, like, this is something like I wish anesthesia would massively advocate for, is should we be using more, even if it's non-invasive, stroke volume measures when you've got like these big abdominal surgeries or, whatever the case might be? Should we be using hemodynamics and not just guessing? Because if you're using heart rate and blood pressure to decide if your patient's fluid responsive, you're guessing. You are totally guessing.
Right. Right. Yeah. Usually the bigger cases we do have different ways to measure. I think a lot of room for improvement can be done in those cases. And I would love and encourage those of you listening, if you're going to be thinking about a D&P project, that this could be a light bulb going off saying, let's focus here and see if there's a way that we can improve patient outcomes by doing some stroke volume measurements during big abdominal cases or other cases where there's a lot of fluid shifts going on and third spacing, or even the patients who come down to the OR who already have a lot of disease going on. Who are at high risk, like a septic gallbladder could be one of them. Those can go bad so quickly that, having those types of measurements in the OR in real time would be a life-saving measure. So thank you. That's great. All right, let's see what else about here. We talked about the reflex bradycardia. That definitely does happen. It depends on the dose that you give, how significant the bradycardia can be. Never seen them go asystolic. So just so you know, I've given pretty high doses myself, and I've never seen them go asystolic, but it does significantly slow them down. Metabolic acidosis, is this related to the increase in SVR and potentially or what would that be caused by?
Well, it could be multifactorial. Definitely it could be worsening shock state, right? We see metabolic acidosis and shock so frequently. So, and a lot of that is multifactorial, just like understanding if you're using these vasopressors, you often do see metabolic acidosis. So,
yeah. Could be from like a VQ mismatch of some kind. All right. Well, then let's move on to, I wrote down a notes of all the, milrinone. That was the one we want to jump to next.
Oh, milrinone. Yeah. Mm-hmm.
Yeah. This is a drug that I feel like, maybe it's just speaking for myself, but I feel like I wasn't super familiar with it. I knew about it in the ICU, but I didn't use it a lot. and you don't even use it a lot in anesthesia, but when you do, it's a very important drug, and it can be life-saving. So let's talk about like uses and how it works.
Yeah, so milrinone is it's a phosphodiesterase inhibitor, and it has a little nickname called an inodilator. So it's a positive inotrope. It's going to increase contractility by inhibiting cyclic AMP at the cellular level, but it also vasodilates. And so, that's which in a lot of situations, that's good because you're getting a positive inotropy and then less resistance to pump against. But here's the deal. I was actually on a webinar a few weeks ago, and this cardiac surgeon was talking about milrinone versus dobutamine. He's like, I love milrinone, but man, I always got to bring her best friend with her, norepinephrine, right? Because
Yeah.
the vasodilation can cause hypotension. And, like with dobutamine, so dobutamine is a catecholamine inotrope, and it's quick on, quick off because it's a catecholamine. Whereas milrinone has a lot longer half-life. The half-life is about 2.5 hours.
Wow.
And so, so when you use it, it works. It's an awesome drug. It works great, but you've got to have some pressure to play with or the willingness to start a vasopressor if needed. So, it's an awesome drug. About 2.5, 3 years ago, it was studied head-to-head against dobutamine in shock states, and it came out pretty equivocal results compared to dobutamine. Although I have to say, like in a lot of shock states, I think we're more comfortable with dobutamine because of the catecholamine nature and like quick on, quick off. If they get hypotensive, you can just back off, and the half-life is just a few minutes. So, but milrinone, I love using like in exacerbated heart failure patients. It works beautiful because you get the dilation it's a lot more significant than what you get with dobutamine. So dobutamine, you do get some vasodilatory effects, but it is far more pronounced with milrinone.
Yes, and I agree. They usually need a best friend. We would use it after our open heart, and we typically always had to have levo on with it. And we had to be careful when we titrated it because, like you said, the half-life is so lengthy that you go so slow and start so little with that drug, because if you have to get it off, then now you're kind of stuck with the effects for some time.
Yeah.
But it's a great drug when it works. We would use it a lot. I mean, again, pressure dependent. Patients who had like pulmonary hypertension were great patients for it and things like that.
Yeah, you get anyone who's got like right heart issues, you do like, I love it in right heart issues because it keeps the blood forward flowing to the left.
Yes.
So it does definitely work great with right ventricular dysfunction.
Yep. Very cool. So awesome drug. And let's see anything else. So it is excreted or metabolized by the renal system. So if you have renal failure, is it complete contraindication, or just be careful with it?
You use less of a dose a lot of times. I mean, yeah, I mean, that's honest. That's what I've seen clinically. And then if there are deep concerns, they can, use dobutamine instead. And I've even seen the combination of like, instead of using milrinone, they might use dobutamine with like a really dosed nitroprusside to get the afterload effect. So, you can do a couple different things.
Interesting. And then we mentioned on here in your book, hypokalemia and thrombocytopenia.
Yeah. So the hypokalemia, a lot of times when you see that increased contractility, potassium can come down. So with dobutamine and milrinone, it's always just good to like know what the potassium is, and then just kind of anticipate like it can go down. The other thing is often you're using these drugs with diuretics as well. You're using them with loop diuretics because they're in heart failure. So, another reason, keep a close eye on potassium.
I was not familiar with the thrombocytopenia side effect of it. Is that for like long-term use maybe?
Yeah, and I'd have to honestly like look up the mechanism of why. I don't remember off the top of my head why, but it is listed in almost every textbook you look at as a side effect. I'd have to dig and look up why.
Yeah, that's fine. And my guess is probably over a period of time, you guys. I feel like there's most drugs, the longer you're on it, and dose dependent, how high of a dose is usually how a lot of these potential side effects arise. All right, well, very cool. And I think the last one we're going to talk about on today's show is dobutamine. We've already mentioned it quite a bit because it sounds like it's a great adjunct for various types of needs, whether that be sepsis or whether you need a little bit of extra squeeze with some dilatation.
Yeah, I mean, we use it in cardiac dysfunction, heart failure, if you've got right heart failure, left heart, we use it in lots of different situations. A couple things about dobutamine. It's quick on, quick off. But this is not one you titrate fast. Even though it's a catecholamine, it's a catecholamine inotrope. And so any inotropic drug you use, you want to kind of start the drug, give the patient some time. Now, when you titrate this drug, you're titrating to measures of cardiac output. So not blood pressure. I want to be super clear about that. You do not titrate this drug to blood pressure. And because I've seen that done clinically erroneously, right? But like you want to see, like, is there urine output picking up? Is their skin looking better? If you have a central line, a lot of times what we'll do is we'll do a spot check SCVO2, saturation of central venous oxygen, where you draw blood from the brown or distal port of the triple lumen, get your baseline, see where you're at. When you start dobutamine, you should see the SCVO2 go up. So you're identifying its effectiveness by measures of contractility. Now, if you're lucky enough to have a cardiac output and stroke volume measure, those numbers should go up. The SVR probably is going to come down because there is some vasodilatory effect to it. And most patients will start like 2 mics per kilo per minute. Then you might go up to like 3, see how they do. If they need more, then you might go up to like 5. But you want to give this drug some time to work. It's not a fast titrating drug. Your vasopressors for hypotension, you go fast, but you got to come back down fast too, right? But whereas this, your inotropes, you're going to give the patient more time. How much time? I don't know. Like we might start it, give them 15 to 30 minutes, see how they do, and then, reassess from there. But again, reassess a contractility measure. It's not by blood pressure.
Okay. Very good to know. Thank you for clarifying that. So yeah, we
watch for the tachycardia.
Watch the tachycardia.
Yeah, they can get really tachycardic from this drug. So that's one thing you've really got to watch out for, is just watch the tachycardia with this drug.
Yeah, and I see here like dyspnea, and that's probably also from like probably tachycardia,
demand,
shortness of breath. Yeah, like I have an SVT, I can't breathe. Okay, well, very cool. Well, thank you so much, Nicole. This was really enlightening. I had fun discussing all these different drugs with you, and I hope our listeners enjoyed as well. And so let people know how to find this book. For those of you, I have the link in the show notes below, but you just go to your website, which is NicoleKupchik.com.
NicoleKupchikConsulting.com. And it's, I have a tab for it on my website. So and then, and so I'm really excited. It was crazy. I did not realize what a need there was in healthcare for this book. We've sold, like, in the first couple days, over 1,000 books.
Wow.
So
congratulations.
We've been like head down, just trying to get these books, the books fulfilled. But I'm hoping this becomes like just anyone who works with critically ill patients. I'm hoping this just kind of becomes your go-to. In the future, I plan on making an app. I need some time to kind of figure all that out, but I'm hoping to have an app for it, and just keep making enhancements and updating. As there's a couple new vasopressors are being studied right now. So we'll see, what the future shows with those, but I'll update it as needed. So
awesome. Well, thank you so much. And for those of you who follow Nicole on Instagram, she always posts wonderful things, shares a lot of insight on there. So make sure you're following her. And as always, thank you. I appreciate you for listening, and we'll see you guys next week. Thanks, Nicole.
Bye.
Hey, future CRNA. As always, I appreciate you and your loyalty. Thank you so very much for tuning in this week. I'd love to hear from you, so screenshot this episode and share it to your IG stories with your biggest takeaway. Don't forget to tag me at CRNA School Prep Academy so I can personally thank you. Be sure to head over to CRNASchoolPrepAcademy.com to check out our blog and gather free resources to help you along your CRNA journey. Stay strong, and I'll see you next week.